Hello, I'm Saeed Ashina. I'm the director of the BIDMC Comprehensive Headache Center affiliated with Harvard Medical School. This lecture is about tension type headache. I would like to share with you a few facts about tension type headache. Tension type headache is the most prevalent and most common type of primary headache. In its chronic form, it may be difficult to treat. For many years, this headache was neglected by researchers and pharmaceutical industry. However, in the last decades, there have been increasing interest and subsequently more research and improved knowledge about this headache. It is important to note that prognosis for frequent episodic tension type headache is fairly favorable. However, chronic tension type headache and tension type headache with coexisting migraine may have a poor outcome. When you look at 1 year period prevalence of primary headache disorders, tension type headache is the most common and most prevalent one. The prevalence estimates range anywhere from 38 to 74%. The prevalence of chronic tension type headache in the population, which is not shown in this slide, is approximately 1 to 3%. Diagnosis of tension type headache is clinical and based on diagnostic criteria of the International Headache Society. To have diagnosis of tension type headache, the patient must have at least 2 of the following criteria: bilateral location, pressing quality, mild to moderate intensity, or no aggravation of headache with physical activities. In addition, both of the following should be present: no nausea or vomiting, although mild nausea is allowed in chronic tension type headache, and no more than one of photophobia or phonophobia. Pathophysiology of tension type headache is not fully clarified, but we know that both peripheral and central factors play a role. Increased pericranial tenderness has been found both in patients with episodic and in patients with chronic tension type headache. As seen in this figure, in chronic tension type headache, the tenderness seemed to be uniformly increased throughout the pericranial region, and both muscles and tendon insertions have been found excessively tender. In summary, in tension type headache, tenderness and hardness of pericranial muscles is increased. The degree of tenderness is significantly related to headache frequency and intensity, as well as treatment outcome in patients with tension headache. It has also been shown that static exercise can induce increased tenderness in patients. And experimental tenderness has also been shown to proceed to headache. Moreover, decreased blood flow was demonstrated in muscles in patients with tension type headache during exercise. So in conclusion, muscular factors are probably of primary importance in episodic tension type headache, as well as chronic tension type headache. As already mentioned, central sensitization of nociceptive pathways plays a role in pathophysiology of tension type headache. Here we see that with suprathreshold noxious electrical stimulation at both cephalic and the extracephalic regions in both skin and muscle, there are increased pain readings indicating generalized hyperalgesia and evidence for central sensitization in chronic tension type headache. In summary, central factors play an important role in the pathophysiology of chronic tension type headache. We have shown that hyperalgesia is generalized and is of comparable degree in all examined locations. In addition, we found an increase in central pain sensitivity in chronic, but not in infrequent episodic tension type headache. Also, decreased supraspinal antinociceptive activity was observed in chronic tension type headache. We believe that continuous painful input from peripheral myofascial tissues induce and maintain central sensitization, so the normally non-noxious stimuli become painful, and we observe conversion of episodic to chronic tension type headache. Treatment of tension type headache can be divided in patient education, non-pharmacological treatment, acute pharmacological treatment, and prophylactic pharmacological treatment. It is important to inform the patient about the condition, as well as reassure about the diagnosis. It is recommended to set realistic expectations in regards to treatment and prognosis. Discussion about trigger factors is also important. Another important factor is identification of comorbid disorders, such as depression or anxiety, which may need to be treated. Non-pharmacological management of tension-type headache is always rewarding. As I've already mentioned, information and reassurance about the trigger factors can be rewarding. Biofeedback has been shown to be effective in the management of tension-type headache. Cognitive behavioral therapy and relaxation training are most likely effective. Physical therapy and acupuncture may be of value as well. Here is the list of acute treatments for tension-type headache attacks. Acetaminophen in the United States and paracetamol in other parts of the world have been used for the acute treatment of tension-type headache. NSAIDs, or non-steroidal anti-inflammatory drugs, as well as combination analgesics, can also be prescribed. However, it is very important to emphasize the risk of medication overuse or rebound headaches if the acute medications are used on more than 10 to 15 days per month. Prophylactic medications with proven efficacy for tension-type headache include amitriptyline, mirtazapine, and venlafaxine. We usually recommend starting with a lower dosage and gradually increase the dose. Thank you for your attention.